and appreciate you all joining us today, showing interest in and being committed to getting your certified revenue cycle representative session. Again, this is being recorded and will be available on YouTube. So we encourage you, if you do miss sessions, go out there. All 4 previous sessions are up and available for viewing. And it's probably a good refresher as you walk through your training. Also a reminder, if you have not done so already, please sign on to your HFMA account, register for the CRCR course, and then it will be available in your e-learning section on HFMA, very easily accessible right next to the sign-in onto the right-hand side. So there is a lot of material here. There is no way for us to go through all of this in our weekly sessions and get through all 4 units. So you will need to go out there and also take those online courses in addition. However your learning style is, we recommend that perhaps come here, then take the e-learning, or take the e-learning and then come here. But there will be information on the e-learning that we will not get through here. So again, we're going to get started. We had a lot of material last week. We're actually going to finish the last section in Unit 2, and then we'll go through the first 3 sections here in Unit 3. Again, reminder, please disconnect any audio or video at this point in time. All right. Okay. So patient financial communication, and obviously very important that patients understand what their costs are going to be. We're going to talk about the best practices through the concepts of what financial counseling is. Okay. And financial counseling is done to help patients understand his or her health plan coverage and financial responsibility for his or her healthcare services. Components of financial counseling include informing the patient of the hospital's financial policies, explaining healthcare benefits, discussing financial responsibility, hopefully prior to service, assessing the patient's ability to pay through your financial assistance programs or charity care programs or possibly Medicaid eligibility, and then reviewing payment alternatives with the patient, possibly payment plans, possibly loan programs, so that appropriate resolution of the healthcare financial obligation is achieved. And again, hopefully prior to service. So self-pay, you can have your patients that obviously have no insurance. Many of them, we're going to see more and more of that, unfortunately, in the current environment. Even with the Affordable Care Act, many individuals that are not eligible for Medicaid, not eligible for subsidies, some of your working class actually are finding that under Affordable Care Act, their insurance is actually unaffordable to them in those conditions. You want to look for Medicaid eligibility components of it. Many of our clients will work with eligibility vendors to screen those patients, and we'll talk about coverage under Medicaid and some specific guidelines for that. You'll want to ask about COBRA. Many patients now, whether they can afford it or not, might have insurance available through an ex-employer program, and they'll just now have to cover both the employee and the employer cost to get that, cheaper than trying to get it on their own typically, because it's been negotiated, and it's not just a self-insured plan, but many can't afford it. Some providers have been done some unique stuff, particularly through some of their programs and grants that may be through a foundation that have been paying for COBRA, because you're going to get money from insurance more than you're going to get from a patient. Certainly financial assistance is very important to offer your patients, particularly in your not-for-profit world, complying with the IRS 501 regulations and your community benefit requirements. It's better to write it off to charity care, sometimes presumptively, than writing it off to bad debt. And then every provider out there, particularly not-for-profit hospitals, are pretty much offering self-pay discounts, particularly the scrutiny of how self-pay patients were paying more than the negotiated commercial rates. So there was a lot of negativity about that in the media. We then have to focus on self-pay balance after insurance, both deductibles, co-insurance, co-pays, and anything that is deemed not covered where you're able to bill your patient. So the patient financial communications best practices were developed by a task force of industry leaders through HFMA. A complete copy of it can be found in the resources section in the CRCR e-learning program if you want to read more about that. They address the most appropriate ways to conduct financial interactions at every point in what should be a patient-centric revenue cycle. From the moment emergency or non-emergency services are scheduled or a patient arrives for non-scheduled services, compliance guidance is included, as well as an annual training requirements, technology assessments, and annual reporting to the C-suite on this topic. Once the financial responsibility has been appropriately identified, the financial counselor should initiate a conversation with the patient to explain health plan benefits, the price determined, and also help them identify an account balance resolution. During this conversation, certainly prior unresolved balances may also be included in the resolution discussion. So payment options, we do have, full-time, short-term, bank loans. What we don't want to do is get into negotiating a payment plan that is unrealistic for a patient based on their financial conditions. So many providers are going away from that standard. Every balance must be paid within 6 months that some patients simply cannot agree to. They will agree to it so they can have services, and then they tend to end up into broken payment plans. So we want to hopefully customize that for patients as much as we can without extending it out. When I first started revenue cycle, you had payment plans that were, lasted for 10 years. We certainly don't want to do that either. Partnering, if you don't do a good job of it, most providers don't, partnering with specific vendors that focus on Medicaid eligibility screening and determining and working with your patients to get them coverage. Not just for inpatient stays, but finding them in the emergency room, finding them in outpatient, and getting them covered. Again, your financial assistance programs that may include tiered approaches, not just 100% coverage. It may include tier services. I don't know if HMA still has it, but they had an excellent training program for time of service collections and training your staff. So really getting your staff to understand why it's important to address this prior to service, how we can actually help patients versus bankrupting or surprising them on the back with bills that they can't handle. And then certainly guidelines and auditing on processing time of service payments is key in your cash sharing area. So a couple of quick steps, obviously, and these are just some guidelines, right? And I think you could read through those there, but really training your staff on how to have these conversations. This is not a natural conversation for most of your financial counselors on how to ask for money. Many times they just, they don't even ask for it. It's not good for your patients. It's not good for your organization. So invest in explaining to them why it's in the best interest for your patient and the best interest for your facility to collect that money up front, right? And then train them on how to do it. Do some scripting, do some role playing. Invest in that so it's a natural conversation for them is going to be a lot easier. So we talked about some key components of why it's important to both you and your organization and your patients to have those conversations prior to service. May not be natural, may not be what your clinical folks want, but it's truly in the best interest of everybody concerned to make sure you're dedicated to that appropriate financial counseling conversation. Okay, so polling question, what is the purpose of financial counseling? We'll give you about 30 seconds here, guys. I'm not seeing anybody completing it. Diane, is there a issue?
No, I see them on my end.
We're still
Okay, it's just me. Okay, cool.
We're still reading.
Okay, yeah, it's a lot. Okay, give it another 10 seconds or so. As we're doing that, just guys, if you have questions during the session, we're asked to put it into the chat session. Anthony is online. We'll go through those at the end of the session as well. So please feel free to put your questions in the chat. We'll review them and also open it up. So Diane, results? Yeah, number 4, the components of financial education, including informing the patients of the hospital responsibility, assessing the patient's ability to pay, and reviewing payment alternatives with the patient. Okay. All right, let's move on. Thanks, Diane. Okay, patient arrival and intake. We're going to spend a lot of time, hint, hint, on EMTALA. So highly recommend that we focus on and understand EMTALA. We'll talk again about MPI and data collection, and as I've mentioned in a few others, if it's mentioned more than once in one course, I believe it's going to be something that's going to be important. So MPI and data collection is mentioned multiple times in the training. We'll talk about physician education and orders, registration forms, and bed control. Okay. So EMTALA. EMTALA requires hospitals to provide a medical screening examination and any needed stabilizing treatment to every person presenting at an ED requesting evaluation or treatment. Until those obligations are met, the presenting individual can only be transferred out of the facility under narrowly defined conditions. The screening examination and stabilizing a treatment must not be delayed due to inquiries about the patient's method of payment or health insurance status. So patients are initially triaged by medical personnel, where a quick registration record is generated to identify the patient and to specifically allow order entry. After triage, the patient is either placed in a bed or may return to the waiting room if clinically stable. So once the EMTALA requirements are satisfied, then the remaining registration process can be completed at bedside or, depending on the patient, in a registration area. Discharge processing, also including the resolution of any patient financial responsibilities, may also occur at bedside. Or many times they may be escorted to a discharge desk, or in many worlds, the nurse puts them out the back door and they never talk to anybody, which is not good for anybody. Certain hospitals do need to ensure that their financial assistance policy is posted very visibly in every registration area, and in many places, discharge areas, and throughout the organization, so that it is readily accessible for patients to understand it, and typically must be posted in multiple languages. So EMTALA again requires that I have to be stabilized before any discussions about financial obligations or transferring to another facility could possibly occur. There are things like called patient dumping, and there's serious fines and sanctions for things like that. So signage must be easily seen that notifies the patients their right to be seen, examined, and treated, along with the hospital's participation in Medicaid. prior authorization is not allowed for emergency department services prior to medical screening and stabilizing treatment. Women in active labor must receive services through delivery. A pregnant woman having contractions is considered in true labor unless a physician can certify after a reasonable amount of time of observation that the woman is in false labor. If an on-call physician refuses to attend to the patient or fails to appear within a reasonable time frame, it must be noted in the medical record and disciplinary action records as well. Referring a patient to another facility that should be completed while the patient is in the ED is considered patient dumping. A patient is considered unstable if there is a risk of material deterioration. Exceptions include cases where the facility clearly does not have the appropriate resources to treat the patient. Both a full medical screening and full psychiatric screening must be provided. And a central log must be maintained that documents all patients that present to the ED and whether they refused treatment, are admitted and treated, stabilized, and transferred, or discharged, and those will be audited. Okay. MPI and data collection. Again, we've talked about the importance of the master patient index and the appropriate patient identifier. The first critical step for all patients arriving for service, scheduled or unservices, is verifying the patient's identification. It's, again, a key concept to understand. It's been mentioned multiple times. Information to identify the patients in the MPI include patient's full legal name, social security number, and/or date of birth. A photo ID may be required as a second means of positive identification. For newborns, initially the mother's registration information is used to generate the newborn registration accounts. Once the parents have named the baby, the newborn record will be separated from the moms. Different types of physicians, and I think most of us understand these concepts, is primary care, usually a family practitioner, OBGYN, pediatrician, or general internist. A referring physician is typically the primary care that refers patients to a specialist for care beyond that scope. And attending, this is the physician who wrote the order for service and is the physician in charge of the patient's care for a specific time period, such as the admitting physician. And then attending or admitting physicians will bring in other specialties to consult for the patient's care. So possibly the patient is in for a liver condition and they need to bring a kidney doctor in to review the patient's care as well. So those are just various forms of physicians, and they'll all obviously consult together. So the physician's decision on whether a patient should be admitted as an inpatient or an outpatient requires medical judgment based on the patient's medical history, current medical records, and the risk of something adverse happening to the patient. Medical documentation must support the level of care. Patients are admitted to inpatient status if further treatment can be provided in a hospital setting, the patient's condition cannot be evaluated and/or treated within 24 hours, or there is not an anticipation of improvement in the patient's condition within those 24 hours. Hospitals can only convert an inpatient case to observation if the Hospital Utilization Review Committee determines before the patient is discharged and prior to billing that an observation setting would have been more appropriate. Physicians must be admitted, notified, agreed to, and document this change. Observation services are used to evaluate patients for possible inpatient admissions or to resolve problems where treatment is expected to last less than 24 hours. Using observation status allows the physician time to determine if admission is necessary, reduce denials for unnecessary admission, and ensure some payment is received for services that rendered. Services that do not qualify include convenience reasons, routine prep, routine surgery, certain therapeutic services, and procedures designated as inpatient only. Two-midnight rule. We've had this topic multiple times. Again, recommendations to understand it. Physician needs to reasonably believe that the patient will be inpatient for at least 2 nights to treat their condition, and as such, then can be admitted as to an inpatient stay. Okay. Anybody who's worked in patient access knows there are a lot of forms that need to be resolved and going over with patients and signatures obtained. So except in emergency services, a consent document should be completed by every patient. It must include 4 conditions. Must be related to treatment, must be informed, must be voluntary, and must not be obtained through fraud or representation. Conditions of admission include medical and surgical consent, release of information, financial agreement, and assignment of benefits. The privacy rule is obviously issued to implement the requirements of the HIPAA Act of 1996. It addresses the use and disclosure of an individual's health information. Hospitals must notify all Medicare beneficiaries who are inpatient that they have the right to dispute the hospital's discharge decision utilizing the important message from Medicare, and they do have the right to dispute. The Medicare Outpatient Observation Notice, however, or MOON, is required for all Medicare patients who are in an observation status for more than 24 hours. The notice must explain why the patient is an outpatient and discuss the implications of that, particularly related to the patient's out-of-pocket cost. The patient has no appeal rights, whether they are observation or inpatient. Obviously, the advanced directives, we've got 2 different types: a durable power of attorney, where they actually name somebody who could be representing them in medical decisions. And then also another just blanket kind of advanced directive that doesn't specifically name somebody, but they will want to bring in a patient advocate even if they're not named. And the Patient Bill of Rights is written to just protect both the patient and actually the healthcare workers as part of the stay. I'm sure anybody in registration is very familiar with those. Bed control, otherwise known as census management, is the activity in which results in the accurate recording of the patient bed status and level of care assessment, patient transfer, and patient discharge status on a real-time basis. Clinical and service departments use bed location information in the delivery of services. Daily room charges are calculated based on the patient's location and level of care at midnight each day. Beds are assigned based on the patient's diagnosis and clinical condition. Many times the physician order will include a preferred location. Most hospitals have units that are set up to treat certain patient types. Common dedicated units include surgical, orthopedic, critical care, telemetry, and peds. And patients are placed on different units based on the required intensity of care. For example, ICU, CCU step-down units, and routine care. Each time a patient is transferred, a transfer request must be made to staff responsible for bed assignments. Transfers are required for medical necessity reasons, isolation requirements, security reasons, or unit utilization needs. So obviously the physician must write the discharge order. Case management, discharge planning must be finalized. Appropriate discharge instructions must be provided to the patient. Access services must review the patient records to see if the patient needs to see a financial counselor prior to discharge. And when the patient leaves, the registration system must be updated to reflect the correct dates and times of discharge, the correct disposition code. Example, did they go to home? Did they go to a nursing home? Did they go to a SNF? Or did they go to a rehab? So key points, and I apologize that that is so small to read. Again, the PowerPoint will be available up on that you can look through, but just those things that you want to ensure that you took away from this session, and when you do your e-learning, particularly things like MTALA, MPI, and some of the forms that will be part of the admission process. So, what does EMTALA require hospitals to do? Polling question. There you go. Give you a couple seconds there, 30 seconds or so. Great. Got it. To provide a medical screening, correct. EMTALA prohibits inquiries about health plan information if the inquiry will delay examination or treatment, or if such activities suggest to the patient that treatment will not be provided unless the patient can demonstrate the ability to pay. For anybody that's familiar with the billing process or even the charging process within the ED, there will always be two levels of charges. The first one is the screening, and then the third is the actual level, from a simple to a complex. There's obviously CPT codes there that will drive those, but that first triage treatment stabilization has to get done by a physician before, and then the additional services will be based on the intensity of it. So good job there. Okay. Oh, one more polling question. If the patient will not stay more than 2 nights, what is the right admission status? And this one should be, you don't have as much reading to do, so we'll cut it off in a few more seconds, Diane. Okay. Observation, good job. Obviously, again, 2-minute rule I think is going to be very important to really make sure that we understand. Great. Okay. Case management. We're going to talk about the purposes and the responsibilities of case management, the different types of case management reviews used within the healthcare organization, and then their roles in the management of patient health care. Again, as providers execute managed care contracts, enter into bundled payment arrangements and other alternative reimbursement models, case management is critical to the success of these programs, along with ensuring that the patients get the most appropriate level of care or follow-up care, and then to avoid readmission occurrence, and then certainly are key to denials and appeals for utilization or medical necessity denials. Okay. So the responsibilities, they monitor the use of resources. They review stays upon admission and throughout the stay, which is concurrent review. They gather information to manage the patient's care, and they provide education for the patient and his family for any aftercare services that are ordered. Discharge plan actually starts as soon as the patient is admitted into the facility or even before. The physician and case manager consider discharge planning as part of the overall treatment plan from the outset. There are 3 types of case management reviews. Prospective review or pre-certification before service. A scheduled inpatient admission, is it required and medically necessary? Concurrent review and discharge planning during service. Is the patient's length of stay appropriate? Is the patient in the appropriate level of care during that treatment? And then certainly retrospective review after service as issues arise. And their purpose is to monitor the progression of high resource consumptive cases to help ensure the effective utilization of resources during the care of the patient and maximize patient outcomes. So case managers are often nurses with specialized training in specific areas. Nurses may become certified case managers by taking specialty exams and having the appropriate credentials and experience. Both case management and disease management are methods used for managing the healthcare of patients. So reiterating, they're responsible for coordinating care, routine contact with the health plan, making sure that all information is provided and needed approvals are obtained, and that discharge planning and execution. If the patient is not moved timely, additional costs will be expended needlessly and can result in denials for not medically necessary. Case managers also assist the revenue cycle staff with written appeals to help plans related to utilization and other care issues. Because they are involved with all aspects of monitoring the patient's stay, they are well positioned to document the clinical reasons for treatment decisions. So, key points: a strong case management is critical both to the hospital and to managing the patient's care. They're often nurses with specialized training. And again, they are working with the revenue cycle to document treatment decisions. Okay. So in what manner do case managers assist revenue cycle staff? Thanks, Diane. I'm trying to say poem question, but so I'll give you a few minutes a few seconds to read that. Okay. Yeah, providing the assistance with denials appeals. So because these clinicians are involved with all aspects of monitoring the patient's stay, they are well positioned to document the clinical reasons for treatment decisions denied by the health plan. So they may do all the rest of it, but specifically, how are they working with revenue cycle staff is in the denials and appeals process. Great. Okay, moving on. Okay, this is our last section, and then we'll open it up for questions. So revenue capture, we'll talk about the charge process and its impact on revenue cycle. We'll talk about the components of the charge master are commonly referred to as the CDM, and then the maintenance and the importance of the maintenance of CDM to ensure appropriate reimbursement. And I have a horror story to share with you on that one. So accurate charging of healthcare services is critically important, as the accurate recognition of revenue associated with the services provided is the basis for revenue recognition in the provider's financial statements. Many providers, clinicians, etc., believe it's not as critical because they're not typically being reimbursed based on charges, because few plans pay for that. It's still important. Some are based on a percentage of charges or stop loss provisions, and they need to reflect the charges. But again, we need to reflect appropriately the actual revenue recognition within each department. We mentioned that the room and board is typically posted from the midnight census. Ancillary services are typically recorded, sometimes still antiquated, but when the service or supply is ordered, or maybe when the result is actually reported. Scanning barcoded items as they are used, typically in the surgery or materials management. Pharmacy, typically when it's dispensed from a system like, say, Pyxis. And then certainly charges based on length of time or acuity. When I was in the provider space, I'd walk through the floors and I would see all these little stickies all over these nurses on the stuff that they dispensed that they had to remember to record. So that was back in the old days. Again, I am routinely aging myself here. So audit trails are vital to ensure that all resources consumed are charged. Charges are grouped by revenue codes for billing, logging, and case mix reporting. Most items have CPT4 or HCPCS codes attached to them to make them easier to compare and track. So what is the charge master? We're going to spend a little bit more time on these core things. We're just focused on what it is. The charge master is primarily a list of services, procedures, room accommodations, supplies, drug biologicals, and other radiopharmaceuticals that may be billed to a patient, either inpatient or outpatient. It includes the charge-specific data needed for claim submission. So what are the core elements? So everyone has to have a CDM number. It's a unique identifier assigned to a given line item in the charge master. The department number will denote the revenue generating area. Is it lab? Is it radiology? Is it cardiology? The charge description that appears on a claim or a statement that hopefully is meaningful to a patient. The dollar amount or total charge amount. The current procedural terminology codes are CPT codes that are maintained by the AMA. They describe services, procedure, and drugs. They are updated in January and July of each year. HCPCS codes are maintained by CMS, and they describe services, procedures, DME, supplies, and drugs. Those are updated continually throughout the year. Now you can understand why maintaining charge masters may be a little bit complex and difficult for providers. Modifiers can also be part of a CDM if it is consistently used with a CPT code or HCPCS code, but also can be coded by coding at the time that's completed. Every CPT code and HCPCS code is assigned to a revenue code, so those can be appropriately reflected on the claim to the insurance carrier, and each should have a general ledger or GL number to go into your financial reporting. Okay, charge master challenges. Again, very difficult for people to maintain. The omission of charges if they're not in the charge master or they're not entered by clinical staff. Serious complications if you've got obsolete or invalid codes, and the impact of these issues are missed revenue, claim denials, and negatively impact reimbursement. And the omission of required modifiers can basically either impact reimbursement or be a compliance issue. When I started at University of Maryland, I actually came on board as a rev cycle director after a stint by a consulting firm. And when I walked in there, the AR and everything was just fabulous, right? Days in AR were great. Cash was wonderful. They'd done a lot of cleanup. And as I was there for a few months, hadn't changed anything, but started to see some serious denial issues, started seeing some serious cash issues. And so of course I'm getting a little nervous here, chatting with one of my billing directors, and she said, well, let me show you this. And she walks me into a room and there's a pile of books this high that the consulting, they had a consulting firm come in and do a complete review of their charge master and identified every inaccurate charge that was in there, right? These were CPT codes that were no longer valid, but we were still submitting them in our charge master. So the consulting firm came in with the full, every department had that CDM review done, but they did nothing with it. So they continued on and on to get those denials. At that point in time, they were a year old. There was absolutely no way to take that and feel that they were valid. We had to start all over again. We chose to do it by department. We identified the highest risk areas, the higher denial areas, like lab, and we did lab first. We dedicated it to that. We had somebody come in and do another review. We implemented those changes. And then we made sure we maintained them by bringing in technology, creating a charge master team that really focused on that, because the implications to the revenue cycle and to cash and to completely ineffective processes by getting those denials is significant. So the impact of it, the challenges are there. You've got to focus time and energy on it. So often the maintenance of the charge master is assigned to a specific individual or department. Sometimes it's compliance, sometimes it's revenue cycle. However, others within the organization must be involved in adding, revising, deactivating charges, and educating them on the importance of it. So as we said, it is important it is reviewed and updated regularly, and that it supports and represents services provided within the organization. Okay. HCPCS codes and modifiers. So level 1 modifiers are approved Medical Association CPT-4 codes. They are all 5 digits. CMS developed codes level 2 for classifying supplies and non-physician services such as DME, ambulance, and drugs. Level 3 HCPCS codes are assigned by the MACs. These codes are not common and are used basically to describe new procedures not yet developed in level 1 and level 2. I had a conversation yesterday with a client that does tumor imaging DME supplies, and they are a level 3 DME supply because it is so new in the industry. So that's when those things are used. Modifiers, again, are typically assigned via the charge master process, but some can be assigned via coding. Level 1 can discuss common scenarios, such as did I do a bilateral procedure or did I do a multiple procedure? Level 2 will designate a right or a left side or a body part, such as part of the eyelid, the hand, or the artery. Level 3 modifiers differ significantly because they are assigned by each MAC, such as cosmetic surgery, not commonly covered, or an FDA-approved drug. So again, the level 3 are assigned by each MAC and differ widely as to its utilization. So common issues that cause issues with appropriate charging and coding is the incomplete or vague physician dictation or documentation. Documentation not being complete and they're coding from a face sheet. Using symptoms, that should say symptoms, instead of specific diseases. And then a coder mistakenly choosing a primary diagnosis and procedures that are not accurate. So those are common issues in coding and charge master that can absolutely occur. So key points is remembering that charge capture, even if not reimbursed by charges, total charges, etc., is pretty key to your organization for financial reporting and a true reflection of what you did for that patient. The importance of maintaining your charge master to your organization and the differences between CPT codes, HCPCS codes, and the modifiers that are appropriate for each level of care. Okay, So quick polling question. Why is it critical that the charge master is reviewed and updated regularly? Okay. A lot of you answered number 4, and so I could see that. The actual answer per HFMA is number 3. So again, nuancing it, read through that section really carefully. The wording is that this is the actual question that was done on the HFMA e-learning. You'll see that when you take these, they kind of move the questions around and the answers around. But I could see what that would be confusing. So gonna recommend that you read through that charge master information a little bit more nuanced. So, okay. Okay, which HIC-PIC level modifiers are maintained by the max? Give you a few sessions here. Okay, Diane, let's close that one. Level 3, good job, guys. I tried to make sure I prefaced that quite a few times during that conversation, so great. Well, we're gonna open it up for questions. If anybody would like to join us on video, ask a question live or audio, we recommend that you do that. I'm gonna turn it over to Anthony to basically, one, talk about some of our upcoming events that we have, and then we'll go over the questions.
All right, thank you so much, Christine. Another great session here today. Thank you, everyone. Just want to remind everyone that the chat is open, so please go ahead, and if you'd like us to touch on anything or kind of expand on any of the topics we discussed today, please go ahead and pop those in the chat, and we'll get those addressed. While we wait for that, I just wanted to give everyone kind of the heads up of a really awesome event we have tomorrow in conjunction with Florida Sunshine of AHAM chapter. We are having our Halloween Spooktacular, which is essentially 3 1-hour education sessions, one at 9:30, or excuse me, one at 10, one at 1:30, and one at 3 p.m. And during lunchtime, we have a really special event. We have a Name That Tune challenge, where it's essentially an interactive competition amongst all participants, where we have a DJ, his name is Jason, who will be playing some songs, and we'll be asking some questions on those songs, artists, or naming the song itself. And we did a couple of practice runs, and it should be a really, really awesome and fun event, and a good opportunity to network with others in the chapter. So go on floridahfma.org/events and go ahead and register. It is free and open to anyone, member or not. So go ahead and get signed up for that. We're looking forward to seeing you all tomorrow. And don't forget to dress up. There might be a special prize for those that go above and beyond for their costumes. So again, that's tomorrow from 10 to 3 p.m. November 5th, we have our part 2 of our Decision 2020 election series, where we're having an amazing panel of speakers moderated by Kathy Reep with PYA. We have Chad Mulvaney from HFMA National, Paul Miller from the Legislative Committee of AHAM, and a little South Florida representation from our friend Jamie Caldwell and the South Florida Hospital and Healthcare Association. It's a 90-minute session where we'll be going over post-election, now what, which is why that's what it's called. So it'll be an interesting discussion on that. So look forward to that. And then finally, getting into our holiday special, on December 10th, we're having our holidays happy hour and networking event, along with some educational sessions. And that is, again, December 10th, starting at 2:30, a session, a 4 o'clock session, and then the happy hour holidays ugly sweater contest and scavenger hunt at 5:15 p.m. I'm seeing that, oh, there you go. Diane just put the links there to register. but you can also find those events at our event page as well. So please sign up. Again, they are all complimentary admission and open to anyone who would like to participate, network, and get to know a little more about these fun events that we put on. So let's dig into these questions. Let's see what we got. No questions.
Okay.
How do we sign up for Spooktacular? We got that. Oh, I did find one. Misa Scott asked if you could please go back over the Charge Master elements briefly.
Okay, yeah, let me bring back this screen because I did stop sharing. So let me go back and bring this back up. I won't go back into full slideshow, but give me a minute here. I got to go further up, sorry. Quickly go through this. And this will be fully listed out in the, here we go. Yep. Core elements, okay? So your charge master number, department number, again, all that's for identification and revenue generating. Certainly your billing description, charge amount, and CPT codes will drive what's billed. Modifiers will also drive, compliance and reimbursement issues, and some, again, identification of, was it a bilateral or multiple procedures? And revenue codes also drive billing on a UB is required for that billing format. And then certainly GL for financial reporting as well.
Great. Well, while we're here, Patrick asked if we could just go over the HCPCS modifier levels again. If we can
Sure.
get back into that.
Okay. So level 1, level 2, and level 3. Hold on a minute. I'm going to go into slideshow from here. Hold on a minute. Okay. Level 1, the modifiers are the HCPCS codes. So level 1 are the approved medical association CPT-4 codes. CMS developed the level 2 codes for classifying supplies, non-physician services such as DME, ambulances, and drugs. Level 3 codes are assigned by the MACs. They are codes that are not common and are used basically to describe any new procedures that have not yet developed in level 1 and level 2. So newly approved FDI drugs and supplies and things like that, so they can get reimbursed. Many times what will end up happening is that over time, those level 3 codes may get turned into level 2 codes or even level 1, depending on what the categorization is. The modifiers are level 1 is common scenarios such as a bilateral or a multi-procedure. Level 2 is going to designate whether it's the right side or the left side of the body. Also attributes things like part of the eyelid, the hand, body parts, or arteries. Level 3 modifiers will differ significantly across the country because they are assigned by each MAC. Some examples are cosmetic surgery was performed, which is not commonly covered, or an FDA approved drug. Okay. Other questions, Anthony?
There's none right now. Anybody else have anything you'd like us to touch on here quickly before we wrap up today's session?
Yeah, again, highly recommend that between this session and next session, you get out there, get into e-learning, do the 4 sessions we have. Feel free to bring questions or send questions our way. We're here to support you, not just during these calls, but offline as well. Okay.
Yep, and Diane, has placed the 3 registration links in the chat, direct links to this event registration for those upcoming events. So you can just click them right now and get yourself signed up and join the fun.
Thanks, Diane. Hope to see many of you on our call tomorrow. Again, anything you need between now and next week, just let us know. We're here to support.
Yep. Thanks, everyone. Thank you,
Thanks,
Christine.
everybody.